For this webinar series of Naidaniki. We are arranging every year the webinar series in January, February, August, and September. Theme for the current series is CT scan diagnosis, which was started from 2nd of August 2025. And for that, we had our first lecture on basics of CT scan diagnosis and CT chest diagnosis. And today's webinar is on CT brain and spine diagnosis. We're absolutely glad to have such a distinguished group of medical professionals, academicians, clinicians, PGs, and UG students from various part of India, which are joining us. Your presence are really appreciable. Myself, Dr. Darshana Ubhade, Assistant Professor, Department of Rog Nitan, Tilak Ayurved Mahavidyalaya, Pune. Currently working as a lifetime member and treasurer of female wing of RVPGA. I welcome you all again for today's webinar. This webinar is conducted by RVPGA, that is Rog Nidan Vikruti Vignan PG Association, and is approved by Maharashtra Council of Indian Medicine, Mumbai. I welcome our distinguished speaker, Dr. Amita Thakre, ma'am, who is the renowned radiologist for today's webinar. But before that, let me give you a short introduction about RVPGA. So our organization RVPGA was formed in the year 2016 under the able and dynamic leadership of Dr. Subhash Waghesar with his team like Dr. Subhash, Dr. Santosh Chauhan sir and other members. The aim of RVPG is to give the legal status of pathologists and radiologists to the PGs of Rog Nidan. Our organization is duly registered under the sections Societies Act of 1860 at Charity Commissioner Office, Nagpur. Postgraduate students, teachers of Rog Nidan, Vikruti Vignan, and Chaya Vikruti Vigyan can become our member. Ours is the only organization which is fighting for the lawful rights of Rog Nidan and Vikruti Vignan. Even the NCSM had also directed the state of Maharashtra to consider RVPGA as stakeholder in consideration of pathology regulatory body of the state. RVPGA is pursuing this matter with state and central government. Not only this, RVPGA is constantly pursuing the implementation of NCSM salary structure in all the private Ayurvedic colleges across the nation. All the communications and details are uploaded on our website www.rupgnagpur.com. You can go and check the website for different activities and latest updates. There are different activities, right? Regular conduction of online webinars and offline seminars, both on national and international platforms. Now we have conducted 37 national webinars on different diagnostic topics, 4 national workshops, and 3 national conferences. 2 hands-on training program for PGs at our partner NABL accredited pathology laboratory across Maharashtra. We have publication of research papers of Nidan students and faculties in our peer-reviewed International Journal of Diagnostics and Research, that is IJDR. Our journal is enlisted in 8 databases. 8 issues have been published, and our current issue had a record number of 22 articles published just within 2 years of commencement of our journal. Interested can visit the site www.ijdrindia.com. We also have an edited book volume series through our international publication RIPI, which is registered in Government of India's ISBN portal. Those who are interested to contribute their book chapters can visit the website www.rvpgaiip.com. We have published all India Rog Nidan PG thesis books consisting of all the Rog Nidan PG titles since 1985 to 2023 for the easy reference of our PGs and faculties. We have a YouTube channel and Facebook page as well. Instagram page has recently launched, where you can see our educational activities past and live and latest updates also. To update our colleagues and students with the recent updates, we have launched 3 diploma courses, which are Diploma in Advanced Pathology Training, X-ray Diagnosis and Technology, and Emergency Sciences and Critical Care Management. We also launched 8 certificate courses like CMIV, CMPD, etc. To know more details, you can again visit our website www.rvpgnagpur.com. We have our e-news bulletins as well, which is biannual published, highlighting the achievements of our members. We are giving legal fights for the issues of Rog Nidan and Vikruti Vignan PGs at appropriate forms. So moving to today's topic. Today's topic is the CT scan, brain and spine diagnosis. So in the first lecture of CT scan, this PPT of introduction has been made by Dr. Pallavi Chaugale madam. So that's what I am using here again. Let's move to the today's lecture. So CT scan, that is computerized tomography, which offers the high resolution imaging of bones, and it's often used when MRI is not suitable. So CT scan brain, which is used to detect conditions like strokes, tumors, head injuries, etc. And it provides the rapid, accurate evaluation of brain structures. Same way, CT spine scans also help in diagnosis of different diseases of spines like tumors, infection, degenerative changes, etc. So today we will gain the deeper knowledge of CT scan brain and spine. And for that, we have our esteemed guest speaker, Dr. Amita Thakre, ma'am. So Dr. Amita Thakre, ma'am, she's an MBBS MD in radiology from MGIMS Sevagram, Varda. She has worked in IGMC and Super Specialty Hospital and Corporate Diagnostic Center previously. Now, Dr. Amita Thakre, ma'am, is working as director and consultant at Noble Imaging and Diagnostics at Manewada, Nagpur. She has special interest in fetal medicine and women's injury. So without any further delay, I would like to request Dr. Amita Thakre ma'am to share her knowledge about CT brain and spine.
Good afternoon, everyone. I will share my presentation.
Yes, ma'am.
I hope, is it visible to all?
Yes, ma'am.
It is visible, madam, but make it in a slideshow version.
Now visible, sir?
Yes.
Yes, it is visible.
Yeah. So once again, I want to thank Dr. Subhash Wage, sir, for giving me the opportunity to speak on the topic of CT brain and spine. And also the Rog Nidan Vikruti Vibhag, because they are repeatedly offering me the opportunities to share the knowledge with you. So today we are going to learn about and gain knowledge about this diagnostic interpretation of CT brain and spine. What I am going to do is that I am going to cover, there are n number of numerous pathologies and various pathologies in brain and spine, but I will be focusing on the pathologies which are there, which we frequently encounter. So the common etiologies and the pathologies will be covered. So now, whenever there are, we can do X-ray of the skull, we can do CT scan of the skull, we can do MRI of the skull. The advantage of the CT is that it is fastly done. The time, the patient in and out time is hardly 5 minutes. It is easily done. So in case of a patient who is unconscious and we need a quick diagnosis, CT scan is advisable. Also, the CT scan advises high resolution of the bone window. So whenever we want to see about the fracture of the bones of the skull, the CT scan is advisable. So the common indications are trauma, stroke, dementia, infections, headache, and also the follow-up in case of the operative events. So first, I will be telling you about the anatomy of the brain, so that can be correlated on the CT scan images. So we have 4 lobes. In supratentorial compartment, the cerebral hemisphere, they are divided into half by the interhemispheric fissure, and each cerebral hemisphere, now it is divided into 4 lobes. So the lobes are the frontal lobe, the parietal lobe. They both are divided by the central sulcus. Then there is occipital lobe, which is divided by the parieto-occipital sulcus and temporoparietal sulcus. Now this one is the temporal lobe. Coming to the
मैम
infratemporal fossa.
स्लाइड
हेलो,
चेंज हो नहीं हो रही। मैम स्लाइड चेंज नहीं हो रही।
ये स्लाइड आपको कौन सी स्लाइड दिख रही है?
इंडिकेशन ट्रॉमा स्ट्रोक डिमेंशिया
ये वाला नहीं दिख रहा है?
नहीं।
एक मिनट,
हाँ अभी आया, अभी चेंज हो रहा है।
अभी चेंज हो रहा है, एक मिनट।
Ma'am, can you make it full screen?
जस्ट अ मिनट। एक्चुअली ये ना मेरा जो विंडोज है दैट डजंट सपोर्ट आई थिंक दिस गूगल मीटिंग, मतलब जो जूम वाला है वो। एक मिनट।
मैम नीचे बार में उसका ये है आइकॉन।
नहीं, ये स्लाइड शो ना?
यस यस।
हाँ, पर उसमें स्लाइड नहीं चेंज हो रहा है ना, आप बोल रहे हैं। अभी चेंज हुआ क्या स्लाइड?
जस्ट थोड़ी देर पहले हुआ था।
ये देखो, ये अभी हुआ है चेंज?
नो मैम। यस अभी हुआ।
हाँ, पर ये तो मैंने वो लीव किया ना, तब हुआ।
ऊपर स्लाइड शो का ऑप्शन है मैडम,
ऊपर स्लाइड शो है लिखा हुआ है।
हाँ,
फ्रॉम द बिगिनिंग, फ्रॉम द बिगिनिंग।
तो चेंज झाले का स्लाइड?
नो
होता है
मैम,
वही।
इट्स
नहीं
ग्रीन
नहीं
स्लाइड थर्ड वन।
आता स्कलचा इमेज आहे का सर?
हाँ, स्कलचा इमेज आहे ना।
हा स्कलचा इमेज आलाय ना?
नाही आम्हाला नाही दिसत अजून।
दिस इज द थर्ड स्लाइड मैम, showing the different lobes.
हाँ, अभी स्कल चेंज हुआ?
No.
नाउ
No.
फ्रॉम बिगिनिंग वर एकदा परत करा मॅडम।
हाँ. Double check.
आता होतंय का चेंज स्लाइड?
नाही
मला वाटतं इट्स टेकिंग टाइम ते
फर्स्ट स्लाइड दाखवत आहे का सर आत्ताही?
फर्स्ट स्लाइड दाखवत आहे इंडिकेशन्स वाले। मला असं वाटतं ते होऊन जाईल, नेक्स्ट कराल तर ते कदाचित
आता झालंय का चेंज?
चेंज नाही झालाय।
हाँ,
समहाव ते चेंज होत नाही ऍक्च्युली। ते फ्रॉम बिगिनिंग केलं की ते फुल स्क्रीन येतो, बट समहाव ते होऊन नाही राहिलंय। बट ठीक आहे ना, आता अशा या छोट्या विंडो ती चालेल, ते समोर सारखंच जाईल, मॅन्युअली सरकावं लागेल।
हाँ, मॅन्युअली मी करून घेईल सर, फक्त मला हे वाटतं की दिसायला पाहिजे बस तुम्हाला सगळ्यांना।
हा दिसत आहे मॅडम, दिसत आहे।
आता हे आय थिंक दिस इज बेटर, फुल स्क्रीन
Okay.
मोड। आता होतंय का चेंज?
Yes.
दिसत आहे पण
होतंय
इट
मॅम.
इज ओके, विल
तो
वर्क।
चेंज होतंय ना, म्हणजे थोडंसं मोठं
हा
तर
चेंज
झालंय ना? हाँ,
होतं।
ठीक आहे ना सर, चालेल। ओके, सो we now infratemporal compartment we have cerebellum, then we have brainstem. Coming to the skull, now in skull bones, now there are mainly 4 skull bone. We have frontal bone, parietal bone, occipital bone, temporal bone, and sphenoid bone. Now the frontal bone and the parietal bone, they are divided by the coronal suture. Temporal and parietal, they are divided by the temporoparietal suture, and this is the lambdoid suture. Now why sutures are important? The sutures are important because they divide the skull bones, and also if we can see that there are zigzag serrated appearance of the suture in contrast to the fractures which will have a smooth or sharp line. I will show you the images. Now another clinical significance is that here is this is the pterion point. Now the pterion is the meeting point of the coronal suture, this temporoparietal suture. Now this is the thinnest part of the skull. So whenever there is a fracture of the pterion bone, underlying we should suspect the injury to the middle meningeal artery, and subsequently there may be a formation of an extradural hematoma. So the pterion is clinically significant because under the pterion the middle meningeal artery runs. Now once again I am repeating, this is the coronal suture, temporoparietal suture or the squamosal suture. This is the lambdoid suture. This suture is the sagittal suture. Now the sagittal suture, it divides two parietal bones. This is the metopic suture. So metopic suture, coronal suture, sagittal suture, squamosal or temporoparietal suture, and this is the lambdoid suture. Now coming to the anatomy of the brain. Now the brain is composed of gray matter and white matter. Now we have the white matter which is beneath the cortex. The cortex is made up of a gray matter. Underlying it, there is white matter. Also, there are three layers of meninges. The green one is the dura mater. Now, dura mater is the thickest or the toughest meningeal layer, which is closely applied to the inner table of the skull. Next layer is the arachnoid suture, arachnoid meninges. Now, this is the in brown color. Now, this dura mater and arachnoid mater, they are closely opposed to each other. Underlying the arachnoid, we have subarachnoid space. Now, subarachnoid space is the space between the arachnoid matter and the pia mater. Pia mater is very thin layer of the meninges which is applied to the surface of the brain. The subarachnoid space is important because usually the vessels, the artery and the veins, they run through the subarachnoid space. So here what we can get is we can get a subarachnoid hemorrhage. Also, whenever there is infection of the meninges, that is meningitis, we get a dense echos or a dense material between the dense, we can say, bacteria and every infection which is seen in the exudates, we can say exudates, they are usually seen in the subarachnoid space. Now this is the cortex which is made up of gray matter. This is the inner part of the brain which is made up of a white matter. This layer here is the falx. Between the falx or the interhemispheric fissure runs the sagittal sinus. So correlating these anatomy images on the CT window now. So this is the CT scan of the brain. Now we have a gyrus. This black one is the CSF. Now here we have the gray matter. Here more darker is the white matter, contrary to their name. This depression is the sulcus. This is the skull one. So this green one will be a pia matter. Here will be a dura matter and arachnoid matter, which is closely opposed to each other. This is the subarachnoid space, which is housing the CSF. And in pathology, it will house the subarachnoid hemorrhage and exudates. This depression is the sulcus, and this lobulation is the gyrus. So this is a normal CT brain image. So on CT, we can see that we can have a varied shades of gray. Now this is a darker, this is the brighter one, this is white. So white, what is the bone? Now you have a darker black color, this is CSF or the fluid. Also the fat, it also appears black. See, the gray matter appears slightly white and it is seen in the periphery. White matter is slightly dark. These are the basal ganglia, which are the deposits of the gray matter. So we will get a subtle white appearance. This one is anterior, this one is posterior. Coming to the brain bone window now. This was the brain window. Now this is the bone window. In bone window, we can see that there is outer table. This is the trabeculate and marrow or medullary cavity. This is the inner table. Now we have a typical zigzag or a serrated appearance of the suture. A suture will have a serrated appearance, but however, whenever there is a fracture, it will have a sharp delineation. This is the difference between a suture and the skull. on the skull fracture. This is the anterior cranial fossa, anterior 1/3, middle 1/3 we say a middle cranial fossa, posterior 1/3 is the posterior cranial fossa. Anterior cranial fossa typically houses most of the frontal lobe. Middle cranial fossa have the temporal lobe. Posterior cranial fossa will have the parieto-occipital lobes and also the cerebellum. This PF is the pituitary fossa which houses pituitary gland. These air pockets which we are seeing are the mastoid air cell. This is the ethmoid sinus. This is the sphenoid sinus. These are, as I said, mastoid air cell. Now, this is the sphenoid sinus. The sphenoid sinus can be septated. Here we can see a septation, or it can be non-septated. Whenever there is collection in the sphenoid sinus, we should consider that there is a sign of, this is the sign of a basal skull fracture. This is frontal sinus. Now, frontal sinus have a many anatomical variation. They can have many septation, many frontal bulla or variation. Now, in this case, the frontal bone is not nematized. These are the maxillary sinuses. So here we can see that this maxillary sinus is normally nematized. However, the right maxillary sinus is showing a wall thickening which suggests sinusitis changes. This green color thing is the falx or the interhemispheric fissure which divides both cerebral hemisphere. This one is the tentorium cerebelli which divides the upper part and the lower part of the brain. So the upper part, it houses the cerebral hemisphere. Lower part, we have a cerebellum and the brain stem. Now, the fissures, there are many fissures. This is the interhemispheric fissure. This is the Sylvian fissure. Now, Sylvian fissure is very important because the Sylvian fissure runs the middle meningeal artery, and also it divides the frontal and temporal lobe of the brain. These are the both lateral ventricles. They houses the choroid plexus, and there are some physiological calcification within the choroid plexus. So whenever we are seeing a calcification here, it is not pathological, it is physiological. These are lateral ventricles. Through foramen of Monro, they are connected to the third ventricle. This is the basal system. Furthermore, the fourth ventricle, it is connected to the third ventricle by the aqueduct of Sylvius, which is a narrow CSF canal. This is the central sulcus, which I was talking about, which divides frontal and parietal lobe. This is the occipital lobe. So frontal lobe, temporal lobe, brainstem, and cerebral hemisphere. Gray matter and white matter, as I have described before. So you can see the peripherally we have having a cortical gray white matter. Underlying they are the white matter. Now basal ganglia, these are the basal ganglia and thalami, which are the deposits of the gray matter. So this is a caudate nucleus. This is lentiform nucleus. This is thalamus. Here we are having the internal capsule, and here it is external capsule. So as I've told earlier, caudate nuclei, lentiform nuclei, and the thalamus. Now the infarction occurring here will give a thalamic pain syndrome. The infarction occurring here will give a disorders of the movement. This is the internal capsule. It will have an anterior limb, genu, and the posterior limb. This is the genu of corpus callosum and splenium of corpus callosum. Now the internal capsule, they are supplied by the perforating branches of the middle cerebral artery, and so this area is very susceptible for the lacunar infarcts. This is the corpus callosum. Corpus callosum, it joins two cerebral hemispheres, so they are the joining the fibers, the white matter fibers, the corticospinal tract, they pass through the corpus callosum, and they are the connection between the two cerebral hemisphere. So this is a C-shaped corpus callosum, genu, body, and the splenium of corpus callosum. This is the white matter, which is known as the corona radiata. Basically, they carry the fibers from the cortex to the corpus callosum, and then from the corpus callosum, it goes along the cerebral peduncle to the spinal cord. On the sagittal view now, we are seeing this is the pituitary fossa, midbrain, pons, and medulla oblongata. This is the cerebrum, tentorium, which divides cerebrum and cerebella. Coming to the blood supply, now we very well know that the brain is supplied by the circle of Willis. Now, what is a circle of Willis? So basically, we have an anterior cerebral artery, middle cerebral artery, and posterior cerebral artery. But the God has already made arrangement that if one of the artery is blocked, now the brain can get supply from its collaterals, because brain is a very important organ. So the anterior communicating artery, posterior communicating artery, part of middle cerebral artery, and the P1 component of posterior cerebral artery, the former are. So what if this part is blocked, the blood will supply through this part. If this part is blocked, the blood will supply through the other part. So that way the blood supply of the brain is uninterrupted. So here it is CT angiography images. Here we can see middle meningeal artery. These are the posterior cerebral artery. Now coming to the blood supply, basically anterior cerebral artery, it supplies the parasagittal part of the frontal lobe. Middle cerebral artery mostly supplies the temporal and parietal lobe, and the posterior cerebral artery, it supplies the splenium of corpus callosum and the occipital lobe. Now coming to this is the inferior section. Now it also shows that the middle cerebral artery, it supplies most of the basal ganglia, internal capsule. Posterior two-thirds of this thalamus, it is supplied by the posterior cerebral artery. This brainstem and the cerebellum, now it is supplied by the vertebrobasilar artery. Coming, this is a normal image or the normal CT film which we will get or which we give to the patient. So now what should be the our what should we see on the images? So first of all, as I have told, there are physiological calcification, that is a choroid plexus calcification, pineal calcification. It is always going to be there. It is not abnormal. Now, this type of calcification in the basal ganglia, it is abnormal if it is in very young patient. In old age patient, it is always going to be there. Now, this is the calcification along the falx. On bone window, we can see and see that this is the calcification. It should not be confused with the blood. Coming to the HO densities, the fat and the air, they will appear jet black. The bone will appear white and it is having the maximum HO. Next HO comes that of the blood. Now the blood will also appear white, but it will be less whiter than the bone, and we can differentiate between the bone and the blood by uh, uh, adjusting the window settings to the bone window. Now, as I have told you, this is the gray matter and this is the white matter. So CT brain checklist. So whenever we are having this kind of image, what should we do first? First of all, check the patient and image data and check the image quality. See for skull bone, a brain volume, any abnormality in the brain parenchyma, ischemic change, is there a chronic or acute? Is there any hemorrhage intraaxial or extraaxial? Masses, is there any mass, and the mass effect? Now, what is intraaxial and extraaxial? Intraaxial means that the lesion or the hemorrhage is within the brain parenchyma. Extraaxial means that lesion or the hemorrhage or the exudates, they are in the subarachnoid or the subdural space. So first of all, we have seen patient image data. What is the date? What is the ID? Whenever it was done, right and left marking. Secondly, we now see or the evaluate the CT brain in 3 images: axial image, coronal image, and the sagittal image. This is the brain window and this is the bone window. In brain window, we evaluate brain parenchyma. In bone window, we evaluate skull bones. So now what is the difference? Sometimes apart from these two standard windows, we have to adjust the window setting and we have to see for the pathology. So see, this is the subdural hemorrhage. Now, whenever we have adjusted the window setting, we have make it more black. We can easily see for the subdural hemorrhage. We can also look for the subarachnoid hemorrhage by adjusting the window setting. So now this was the importance of window setting. Now coming to here, see, now in the bone window, we are getting a fracture. See, the fracture is sharp. It is not zigzag. So it's a fracture. But now on vein window, we can see that there is a scalp hematoma and as well as there is extra axial hemorrhage. So this is the importance. So we should always evaluate the patient in both bone window and brain window. Now, is this fracture or is this fracture? See, we have a serrated appearance here that is of a lambdoid suture. Now, this is a suture. Sharp cut going from one table to another table. No zigzag thing. Now, this is a occipital bone fracture. Sharp edges here. Now, this is a zigzag image. This is a suture. Here it is sharp. So, and the bone is depressed. So, this was the depressed fracture of the temporal bone, which was associated with the extradural hematoma and the scalp hematoma. Another thing, I have previously seen that we should also evaluate the sinuses. Now, this you can see that the sphenoid sinus is having a fluid within. It means that there is a basal skull fracture. Here we can see that there is a fracture to the right posterior wall of the sphenoid sinus, which can be associated with another fractures. Another thing which we need to see on the trauma patient is the extraaxial hemorrhage. Now, whenever there is a trauma, usually what happens is that the sutures, the dura mater and the subarachnoid mater, now they get separated. Because of the separation, the blood vessel, it ruptures and it forms a collection. Now, here we can see that typical lenticular shaped collection is there, which is limited by the location of the coronal suture and the lambdoid suture. Now, this is the typical appearance of the extradural hematoma. Extradural hematoma is mostly a lenticular shaped collection, which is limited at the points of suture and is usually mostly associated with the fracture. Subdural hematoma. Now, subdural hematoma is the crescent shaped collection. Now, it is in subdural space. It is not limited by the suture. Also, what we can say that the collection now it is causing effacement of sulcocaral spaces. See here the sulcocaral spaces, they are widely spaced, but here they are effaced. So this is the mass effect produced by the subdural hematoma. Difference between an extradural and subdural hematoma, as I have said, it is a convex shape or lemon shape or lenticular shape. However, the subdural is a banana shape or a crescent shape collection, which is not limited by the sutures. Another hemorrhage is the subarachnoid hemorrhage. This is the sylvian fissure. These are the tentorium cerebelli. Now we can see that the hemorrhage is getting along the fissure. So this is a subarachnoid hemorrhage. Also, there is intraventricular extension into fourth ventricle here and in the occipital horn here. This is focal subarachnoid hemorrhage. We can see that in this space, we can see a wide density, which is the subarachnoid hemorrhage. This is the intracerebral hematoma. Now it is within the neuroparenchyma. So it's an intraaxial hematoma, which is associated with subarachnoid hemorrhage. Another patient who is having the fracture, which is associated with the intracerebral hematoma and the subarachnoid hemorrhage, which is causing compression over the neuroparenchyma. See the ventricle here, it is more wide. This ventricle here, it is less wide. So it is causing a mass effect, causing compression over the ventricle. However, there is no midline shift. Midline shift meaning that the midline structures, they are not displaced or gone to the contralateral side. Another patient with the intracerebral hematoma, or we can say it is a contusion with subarachnoid hemorrhage, which is going along the falx. Now, this was all about the trauma patient. Here, to summarize, what we can get in trauma is the first is the fracture, extradural or a subdural hematoma, intracerebral hematoma or contusion, subarachnoid hemorrhage with intraventricular extension. Also, we can get sinus fluid level in case of the sinus bone fracture or the basal skull fracture. The mass effect, it can be there in the patients of trauma. Now, another is the if the patient is having weakness or the hemiplegia or hemiparesis. Now, in fact, what happens is that the blood supply is actually cut off. So the gray white matter differentiation, here you can see that this is the gray matter, this is the cortex, now this is the inner part white matter, but here in this patient we can see that it's a black area and there is no gray white matter differentiation. So this is the acute non-hemorrhagic infarct. Would it have been associated with the white lining here in the subarachnoid space? We would have called it as a acute infarct with hemorrhagic transformation. This can at times associated with the dense vessel. Now this MCA is dense because there is a thrombus within. So whenever we encounter a infarct here and it is associated with dense MCA, we should immediately thrombolize the patient, or we can do some interventional procedures. Now this is a small vessel disease. Now you can see here that the white matter is appearing more black. There are ill-defined hypodensities within bilateral periventricular white matter and corona radiata, suggesting it's a chronic small vessel disease, which is actually due to the vasculopathy, may be associated with hypertension, diabetes. Another thing is the old lacunar infarct. Now, old lacunar infarct, we can say that there are small areas which are similar to the isodense to the CSF. Now, these are the old lacunar infarct. Basically, a infarct which undergoes the degeneration, aging, forms a CSF within. So, neuroparenchyma, it dies and it forms a small pocket fields with CSF. These are the old lacunar infarct. Now, this is the area which is more prone for the old lacunar infarct because it is supplied by small, thinner perforating branches of middle cerebral artery. See, this is the acute infarct, a waist-shaped hypodense area with loss of very white matter differentiation. Now, over the time, the area, the neuroparenchyma, it dies and it forms a CSF filled space. So this is the gliotic area which has formed, and this was the acute infarct. Coming to the brain volume, now this is a 10-year-old patient. You can see that the skull cavity is filled with neuroparenchyma. The sulcopiral spaces, they are less wider. The ventricles, they are less wide. As compared to this CT scan, we can see that the sulcochiral spaces, they are more prominent. Ventricular system is prominent. So these are the age-related atrophic changes in neuroparenchyma. A normal volume and a volume loss. However, this picture can be normal in case of a 90-year-old patient, but this picture in case of a 35-year-old patient, it suggests an underlying neurodegenerative disorder. Here we can see that the ventricles, they are dilated. So this is a picture of hydrocephalus. Coming to the intracranial masses, now here we can see that there is a ill-defined hypodense area. So this is a mass which is associated with the edema. It is now causing compression over the ventricles. There is effacement and rotation of midbrain. So this is the mass effect of the mass effect by the intra-axial mass. Another thing, pre-contrast and post-contrast images. On post-contrast, we can see that there is a peripheral enhancing, ring enhancing lesions, which is associated by non-enhancing edema. So this is mostly a tuberculosis. One can say this looks like a hematoma, but see, it is dural based. It is not associated with any fracture. There is underlying edema. So this is a meningioma. And also this is contrast enhancing images. The hemangioma, hematoma will not enhance, but meningioma will avidly enhance on post-contrast images. Now the intracranial pathological procedures, now they can cause mass effect. Mass effect is the displacement or the compression of the brain parenchyma. It can be due to intracranial mass, hemorrhage, or edema, and it will be manifested as sulcal effacement, ventricular effacement, effacement of basal cistern, midline shift, and a contralateral mass effect. In this patient, now we are having a sulcal effacement here. There is mild compression over ventricle here. Here, see, there is intracranial mass associated with edema. Now it is causing sulcal effacement, compression over neuroparenchyma, rotation of midbrain, and also the contralateral subfalcine herniation of the right side of neuroparenchyma onto the left side. So this is the midline shift. Another patient where, see, this is sulcal effacement. There is large extradural hematoma, sulcal effacement, compression of the ventricle, and also the left side of neuroparenchyma is shifted to right side. So coming to the conclusion now of the CT brain, first of all, we have to see for the checklist, take the history of the patient, where there is trauma, where there is weakness or anything like that. Now check for the symmetry. We should see for the subtle finding. Sometimes there is small area of loss of gray white matter differentiation. Now we should do a window setting and check for the settle sign. So there is no early search satisfaction should be there. If we get one finding, we should not be happy, we should not be satisfied. Okay, हमको ये मिल गया. We should look for the other associated sign, like a blood fluid level in the sinus. It should be looked for. We should search for the every corner, and then only we should conclude our report. So any question for CT bed? Because I will be continuing with the spine now. So now I will continue with the spine. Now, coming to the spine, now in spine, the basic indications are the trauma, preoperative, postoperative evaluation, congenital anomaly, degenerative disease, spondyloarthropathy. For evaluation of scoliosis, because based on the angles calculated by the CT, the correction of scoliosis is done by the orthopedician and infective etiology. Although for the degenerative and spondyloarthropathy and the infective things, the MRI is much more better. So now we have cervical spine, thoracic spine, lumbar spine, and the sacrococcygeal area. We have 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, 5 segments of sacrum, and 4 segments of coccyx. Now, these are the primary curves. They are seen in the thoracic region and the sacrococcygeal region. Secondary curves, that is a lordotic curves, they are noted in cervical and lumbar region. A typical vertebra, now the anatomy is really important here because this is what we are going to see on CT images. So vertebra, it consists of the vertebral body and the posterior element. The posterior element will have the pedicle, transverse processes, lamina, spinous processes, and this canal in between is the spinal canal. So in the spinal canal runs the spinal cord. Now these notches you are getting, these are the pedicle notches. This is the intervertebral foramina. Through this intervertebral foramina, the spinal nerve roots, they leave the spinal cord. So whenever there is pathology which is affecting this intervertebral foramina, there will be symptoms of a radiating pain or sciatica kind of pain. Now, vertebral arches. So in anterior arch, we have the anterior 1/3 of the pedicle and the vertebral body. The posterior arch will have the posterior 2/3 of the pedicle, lamina, and the transverse processes. These are the cervical vertebrae. Now, in cervical vertebrae, in addition to the other thing, we have one more foramina. Now, this is the foramina for the vertebral artery. So, whenever we have an injury here, the vertebral artery may get injured. Whenever we are reporting a CT or an X-ray, we have to follow 4 curves. This is the anterior line which we get by joining of the anterior longitudinal ligament or the anterior part of the vertebral body. Second one is the posterior line. The posterior line runs along the posterior longitudinal ligament or by the joining of the posterior surface of the vertebral bodies. Third is the spinolaminar line. Now, spinolaminar line, it is maintained by the ligamentum flavum. This is the spinolaminar line. Another one is it is less smoother and it is which we get by joining the tips of the spinous processes of the vertebrae. So here, if we join these spinous processes, we get a spinal line. On the anterior, now this was on the sagittal spine. On the anterior images, now we can have the 2 lines which are joined by the ends of the transverse processes. So, which we have seen the anatomy of the cervical vertebra. Now, this is the cervical vertebra. It looks on the CT. On CT, it will have a body, foramina for the transverse foramina for the vertebral artery. These are the lateral masses. This is the lamina, and these are the spinal processes. Now, this is the spinal canal or the vertebral foramina. These are C3 to C7 vertebrae. This is a C1 vertebra. Now, C1 vertebra is a bit different because it will have an anterior arch and the posterior arch. C2 vertebra, it is also different because it will have a dens or the odontoid process. Also in CT, we should also see for the prevertebral soft tissue. Now, the prevertebral soft tissue, you can see that here it is thin and it is getting thickened here. So, A normal prevertebral soft tissue, it should be less than the 1/3 of the body width above C4, and below C4, it should be less than the 100% of the body width. If this width is increased now, then we should suspect for the prevertebral collection. It may be a hematoma or it may be an infection. Another sign is the hamburger sign. Now these are the superior and inferior articulates, which will form a facet joints, which are seen like this on the sagittal view, and this is seen on the axial view. Now, why this is important? This is important because whenever it is disrupted, we should look for the locked facets or the facetal joint injury. Coming to the thoracic spine. Now, thoracic spine, the from cervical to thoracic to lumbar spine, what one change is constant, that is the width of the vertebral body, it increases. Now, it will have a costo transverse junction, which is there for the articulation of the ribs. See, this is the vertebral body. These are the pedicles, lamina, spinous process. These are the articulation for the rib, and this is the aorta, and these are the lungs. Now, this is the CT image of the whole spine. So this is the cervical vertebra. You can get a transverse foramina. In thoracic vertebra, you get the rib articulation. In lumbar vertebra, the vertebra is robust, larger in size. It will have pedicle, lamina, transverse, and spinous process. In this coronal section now, what we can get is these are the transverse processes. Now, these are the superior and inferior articular processes which are forming the facetal joint. These are the sacroiliac joints. Now, all the the anatomy I was talking about, the anterior 1/3 to posterior 2/3, which I was repeating. It is because it is important because it is used for the classification of the trauma to the spine. Now we have a Dennis classification, AO classification, and TL analysis, the thoracolumbar injury classification system. Now in Dennis, there is 3-column classification. First column is there from the anterior longitudinal ligament, anterior 1/3 of vertebral body, and second column is by the posterior 1/3 of vertebral body, posterior 1/3 of disc, and the posterior longitudinal ligament. Third column is and also the anterior 1/3 of pedicle. Now the posterior third column is formed by the posterior 2/3 of the pedicle, the lamina, spinous process, transverse process, ligamentum flavum, this interspinous ligament, and the supraspinous ligament. Now this AO classification is bit of tedious, and it is not very much useful. Rather than people now they focus for the TL ICS classification because it has more inter-observer variant. The Dennis classification was previously used, but Dennis classification, it suggests the overtly towards the surgical correction. So the thoracolumbar injury classification system, it takes into account 3 independent predictors. First is the morphology: compression, burst, translation, rotation, or distraction. Integrity of the posterior ligamentum complex, it is intact, suspected, or injured. Neurological status: if neurological status is intact, nerves are intact, cord is injured or not, incomplete cord injury, or a cord icon injury. Now, if the score is between 0 to 3, it is non-surgical. In case of 4, it should be a surgeon's decision. More than 4, it is surgical. What is compression fracture? The compression fracture is simply compression of the vertebra. It is causing a wedge deformity. So the vertebral height, it gets reduced and it forms a wedge. Burst fracture, now the burst fracture, it have a compression. It is associated with the retropulsion of the supraposterior body fragment into the spinal canal. Now it is associated with the spinal cord injury. Translation rotation fracture, there are forces which cause a rotation and the shearing of forces. There is either anterior or lateral displacement, facetal joint displacement is there, and always a neurological injury. Now, distraction fracture, it is usually horizontal fracture of the posterior fragment, which separates the posterior elements. So coming to the compression fracture, I will show you these images later on. We will see it on CT. So we can see that the here the vertebra, it has a reduced height. Here we can see a fracture fragment. So there is a cortical break, there is wedge shape, and there is a horizontal band of trabecular impaction. So usually the superior end plate is usually injured, and the posterior cortex of the body, it is intact. So this posterior intact body, it distinguishes compression fracture from the burst fracture. See here. So first of all, we should have the three lines. So the anterior line, it is intact. Posterior line is also intact. This line is also intact. Now coming here, we can see that there is subtle break of here, cortical break is there. On axial section, thin sections, we can see the fracture. So this is a wedge compression fracture. See, this is the wedge compression fracture. The white line which we are seeing here, it is a depressed, compressed bone. It is not a sign of healing. And also when we compare the height of the vertebral body, it is reduced. Another patient, here it is the MRI, it is a CT. We can see a break in the anterior cortex, as well as there is reduction in the vertebral height. So this is a compression fracture. Here it is more nicely seen. And also another vertebra which is showing a decrease in vertebral height, and its fracture, it is more nicely seen on the MRI images. This vertebra is also showing the fracture. So you can see on CT these two fractures we suspect, but the MRI also shows this fracture of the third vertebral body. That's why MRI becomes successful in case of the suspicious fracture detection. Coming to the now burst fracture. So coming burst fracture, there is wedging, there is wedge compression, but the posterior cortex now it is not intact. It gets retropulsed, posteriorly placed into the spinal canal. See here, what we can see is that this anterior line is maintained, but this posterior line is not maintained. There is significant reduction in the vertebral body. These fat density areas, now these are the vacuum phenomena which occurs whenever there is compression. So there is compression of the vertebral body. There is fracture involving the superior end plate. The posterior cortex is not intact. Rather, it is displacing into the spinal canal, causing spinal canal stenosis, and it must be associated with spinal cord injury. Also on axial images, now we can see that there is laminal fracture here, a laminal fracture here, and here also. So both sagittal and the axial images, they are important. Translation fractures, now translation rotation fractures, it will have the anterior or lateral displacement, a fascial joint disruption dislocation. It may be associated with rib and transverse process. So on CT, we can see a oblique linear array of bone fragments. The posterior ligament complex is almost always involved. See here, what we can see here is that first of all, whenever we are coming to CT, now we are getting the anterior line and the posterior line. So anterior line is not maintained, posterior line is also not maintained. Now this vertebra, it is showing the anterolisthesis. Now this is showing anterolisthesis. This spinous process is showing a fracture. This fascial joint, now they are sitting on one on each other, so they are locked joints. Here also they are locked joints. So this is a distraction or a rotatory fracture. See, in this also patient also we can see a burst kind of fracture. There is associated involvement of the spinous processes, and also there is a rib fracture here. Now, distraction fracture, in distraction fracture, we see that it is more severe. There is horizontal fracture of the posterior ligament. So this is chance type or seatbelt type of injury. See here, there is fracture here, distraction, and also there is fracture in the posterior ligament, also posterior spinous processes. So it's a horizontal fracture. See, horizontal fracture or a horizontal fracture line which is involving vertebral body and spinous processes and this spinous posterior spinous elements. Now on in this patient, what we can see is that we can't see a fracture. Only thing is that this space is increased. This space between the fascial joint is increased. There is fracture here and a fracture here. So this is a chance type of horizontal type of fracture, which is causing separation of the posterior elements and increase in the disc space and the supra space involvement. Another image here, only thing is that both alignment vagara is all maintained, but there is increase in the interspinous distance. And there is thin point of the thin bony fragment here. Now on MRI, now see thin fragment here also. But on MRI, now we can see that there is a vertebral body fracture. Ligamentum flavum is teared. Interspinous distance is increased, and there is spinous process fracture also. So that's why MRI, it is useful in the case of ligamentum fracture evaluation, because this ligament, it can't be seen on CT, but here we can see that there is tear in the ligamentum flavum. Also, as I have told earlier, now you are getting CT. Oh, we can see a fracture here. We can see a fracture here. You get happy, but don't get happy. We can see a fracture. There should be no early search satisfaction. See here, sternum is also involved, and also it is associated with hematoma. Now, with sternum involved, we should always look for great vessels and the heart also. This is another special type of fracture. On X-ray, now what we can get here is that there is ligament ossification or calcification, anterior ligament, supraspinous ligament, and also this kind of lateral involvement. And in this case, we can see a gap or sharp area of here in the anterior ligament and also in the posterior ligament ossification. So these are the characteristic fracture which are seen in ankylosing spondylitis. These are carrot or chalk stick fracture. Here there is ossification, but there is break in ossification, which is seen called as carrot or chalk stick classification. Now, the advantage of CT over the X-ray is that in this patient, we are having a transverse process fracture, a rib fracture, but along with that, we can see that there is a hydropneumothorax here, emphysema here. We can see for the splenic injury, in case of lumbar spine transverse process fracture, a lumbar splenic injury is there, which will need immediate surgery. That was all about the thoracic and lumbar spine trauma. Coming to the cervical spine trauma. In cervical spine trauma, now they have a nexus criteria. The nexus criteria said if there is no tenderness, no neurological deficit, alertness is proper, there is no intoxication or no distracting painful injury, then cervical spine injury is unlikely if the patient has no neck pain or tenderness. Now we have a few specialized kind of injuries in the cervical spine. We can have a hyperflexion injury, which is associated with the anterior subluxation. We can have a simple wedge fracture, unstable wedge fracture, unilateral fascial dislocation, bilateral fascial dislocation, or a flexion teardrop injury. Now the fractures of the C1 vertebra, they are called Jefferson's fracture. The C1 vertebra have the anterior arch and the posterior arch. So the fractures here, they are the Jefferson's fracture. So on CT, now we can get that fracture is seen in the posterior arch as well as in the anterior arch. There is increase in the atlantodental space. So these are the Jefferson fracture. Also, we can see the alignment, it is not proper. So it was a Jefferson fracture which was involving the lateral arch of the C1 vertebra. Also, in this case now, we can see that the patient is having a trauma. The lateral masses, they are displaced. So there is an injury in the lateral mass, and also there is also injury in the lateral mass. Now, this is the occipital condyle, which is also severely displaced. So this is the advantage of multiple multi-slice CT. A hangman's fracture is the specialized fracture we say for the C2 vertebra or the axis vertebra. Now, it is a traumatic spondylolisthesis of the axis bone. Now, there are multiple types. The type 1 is the hairline fracture. In type 2, it is displaced. And in type 3, now they are displaced with the fascial dislocation. Now, the type 3, it is associated with the brainstem compression and immediate sudden death. So coming here, now see that this is the simple fracture at the pars interarticularis area of the C2 vertebra. So this is the traumatic spondylolysis of the C2 vertebra. On the axial images, we can see that there is the fracture line. Now this is the fracture line. There is displacement. So it is the C2 type of fracture, type 2 type of fracture. Another fracture is the odontoid fracture. Now this is the odontoid area of the C2 vertebra. So we will have a type 1 fracture, an oblique fracture. At the base of the dens, it is a type 2, which is associated with the high instability. Type 3 is the lower fracture, or the body of the axis is involved. A type 1 fracture, only upper part of dens is involved. Here, base of dens is involved. It is involving the body of also the axis vertebra. This is a flexion teardrop fracture here. We can see fracture on the coronal images, and here we can say a teardrop is just detached from the vertebra. So this is a flexion kind of teardrop fracture. This is a burst kind of fracture. The vertebral body is completely burst. It is not seen. Now this fracture, it is associated with the transverse foramina fracture. So the vertebral artery is injured here, which will lead to the cerebellar infarction. The facets now, they sit on each other. But here we can see that the facet now, it has this superior articular process. It is seen anterior to the inferior articular process. So this is the unilateral facetal dislocation along with the ankylostasis. On opposite side now, we can see that there is normal alignment of the facet. And also the Hamburger sign, which I have told now, this is seen on this side, but not on this side. So it's a sign of unilateral facetal dislocation. Coming to the bilateral facetal dislocation, the symmetry is not there on both the side. Also, there is ankylostasis. Now, this facet, it is seen anterior to the inferior facet. This facet also seen anterior to the inferior facet. So now these patients have bilateral facial dislocation along with the ankylostasis, and now they are associated with the spinal cord injuries. In a 3D image, now you can see this spine, this superior articular process is seen anterior to the inferior. So this is a lock facet. Now the MRI is telling the severity of the injury. What we can say, there is ankylostasis, stripping of anterior longitudinal ligament along with subligamentous hematoma formation, stripping of posterior longitudinal ligament along with hematoma formation. There is cord cut off. The cord is injured, severely injured here. Almost there is complete transection of the cord. There is injury, stripping of the bilateral ligament of flavum. Also, there is edema and there is fracture involving the posterior element. So now MRI will give you the exact uh, scene of which ligament is involved, what is the condition of the spinal cord. And also in this image, we can see that the prevertebral soft tissue is increased because of the prevertebral hematoma. See now, here we can see that sometimes there is fracture. The location is abnormal, but there is no dislocation because the only there is increase in the joint. So this should be also written in the report. Now in this patient, we have a fracture of the C3 vertebra, a C4 vertebra, a C5 vertebra. Along with that, there is retropulsion. So there is distraction, but not dislocation. A burst kind of fracture, which we can see with the retropulsion of the vertebra. On MRI, it is showing that there is a cord contusion, cord edema, cord injury, along with the injury to the ligamentous complex. We have the flexion teardrop fracture. Because of the flexion injury, we can also have the extension teardrop fracture, which is usually seen in C2 vertebra. So sometimes now, there are subtle signs. So we should always look for the subtle sign. So here there is a break in the cortex. This disc space is involved. It's tiny fracture or a bony fragment here. So now this was the disc space extrusion. Now there is ankylostasis, because of which there is compression of the cord, and here bilateral ligamentum flavum is torn. The spinous process fracture must be there, and there is increase in the spinous distance. What I have told you earlier, that if the transverse foramina is involved in the fracture, the vertebral artery gets involved. So here there is dissection of the vertebral artery. Now it will cause the infarction of the cerebellum. A typical fracture of the spinous process of C7 vertebra, it's a clay-shoveler fractures. Usually the clay-shoveler, they just extend their neck, and sometimes because of the forceful extension, it will have an avulsion fracture of the C7 and T1 vertebra. The interspinous ligament, now it is showing edema. Another entity is the atlanto-occipital dislocation. Now it's an uncommon injury. There can be a complete disruption of the ligaments between occiput and atlas with the subluxation or the partial or the complete dislocation of the occiput to atlantal facets. Now, the anterior translation of skull on the vertebral column is the most common presentation, and the death is because of the stretching of the brainstem, which causes the respiratory arrest. See, this is the normal here. We can see that the basion and the tip of the nails, should have a normal measurement. It is usually less than 5 millimeter. Now, in this patient, what we can see that this distress is increased. Also, the dens is not seen properly. On MRI now, it shows that there is a disruption of the atlanto-occipital ligaments, which is causing this increase in the distance. And it is associated with the spinal cord injury here. However, the brainstem here appears normal. Now coming to the congenital anomalies. Now congenital anomalies can have a unilateral or a complete formation of the vertebra. So it can be a hemivertebra, a wedge vertebra, or a butterfly vertebra. Now the hemivertebra have multiple types: a fully segmented, semi-segmented, incarcerated, or a non-segmented. So on CT now here we can see that there is a hemivertebra which is attached to a one body. Here it's a butterfly vertebra. Here we can see a completely blocked vertebra, a C3 and C4 vertebra, they are blocked, as well as their spinous processes are blocked. Now, these are the incidental finding. It usually does not cause any significant abnormality to the patient. Another patient now, I have shown you that the patient is having scoliosis here. So this is the calculation of the Cobb's angle. The Cobb's angle is important for the correction of scoliosis. Another anomaly is the spina bifida. The spina bifida, here the lamina, they are not firm. So the spine is bifid, it is open posteriorly. Diastematomylia is another thing. So usually there is duplication of the spinal cord. So they will have two sacs, two spinal cord, a thicker sac. It can be divided by a bony spur like this, which will be seen on CT, or there can be a soft tissue spur. Now the soft tissue spur will be seen on the MRI. Is the atlanto-occipital assimilation. So the atlas and occipital condyles, they are fused. So usually the patient will have a neck pain, not other abnormality. For evaluation of this atlanto-occipital assimilation or the base of skull evaluation, we have various lines: Macrae line, Chamberlain line, Macrae line. So here, if we are joining, now this is Chamberlain's line and this is the Macrae line. So the tip of the odontoid process should be below it. If the tip of the odontoid process is above this line, it will tell you about the basilar invagination. So here, see, this is the Chamberlain line and the tip of the odontoid process is above it. So it is showing you the basilar invagination. What it causes is that it causes compression over cervicomedullary junction and thus the weakness. Also, another finding is that atlantodental distance is increased. So basilar invagination, abnormally high odontoid process, it process in the skull bone, it will cause the basilar impression on the cervicomedullary junction. So it is usually seen on the or evaluated on the sagittal images. See, the distance between atlas and the axis is increased or dental increased. So it will tell you about the atlantoaxial instability. Coming to the infective processes now, the spondylolischitis is what we call. It is the infection of the spine and the disc. So it will involve the vertebral body as well as the disc space. It can be associated with the formation of the psoas abscesses. Spondylodegenerative changes, we will have the anterior margin ossified. The disc space here is maintained. It will not be maintained here. There will be sclerotic changes in the vertebra. The vacuum disc phenomena will be there. The posterior marginal osteophytes can be there. It will cause compression over the nerve roots, traversing and exiting, and will lead to a sciatica kind of pain. In spondylodegenerative changes also, we can have these fascicular arthropathy changes. Now see, the fascicular arthropathy is here. The fascicular joint space is reduced. This is the ossification of the posterior longitudinal ligament. Here it is the anterior longitudinal ligament, which is called as the syndesmophyte formation. These are the small nodes, which is the intervertebral invagination of the disc. Another thing is the spondylolisthesis. Now spondylolysis, which will lead to spondylolisthesis. Now this is the pars interarticularis pack. Whenever there is defect in the pars interarticularis region, the vertebra, it goes anteriorly. So what it will cause? It will cause the spondylolisthesis. Now this is how it is seen on the sagittal images. See, there is this posterior line. Now it is not maintained here. The vertebra seems anterior to it. So this is the spondylolisthesis. Pars interarticularis defect on both sides, which is seen on the axial images. The spondylolisthesis have three grades. One is less than 25%, then 25 to 50%, 50 to 75, 75 to 100, and if it is more than 100, it's called spondyloprosis. Post-operative evaluation, because metal implant, they will give the artifacts on MRI. So the position of the metal implant, it is very well seen on the CT scan images. Now, these are the metallic implants in the cervical spine. So here what we see is that is the screw. It is in the pedicle. Now see, in this image, in this side, the screw is in the pedicle. However, here it is seen here to it. So what will happen? The displacement of the implant medially will cause compression over the nerve root. Another is the spondyloarthropathy, the most common being the ankylosing spondylitis. Now, the ankylosing spondylitis will have the ossification of the all ligaments. So here we can see a shaver sheath kind of appearance of the anterior longitudinal ligament ossification. There will be fused sacroiliac joints, fused facetal joints also. Another entity is the metastasis. Now, the metastasis can be lytic or sclerotic. Lytic will cause the destruction of the vertebral body with associated soft tissue formation. Sclerotic will have an increased area of density in the sclerotic, and here it is also causing the wedge compression fracture. So whenever we are reporting CT of spine, we should have the check the alignment, all three lines, anterior, posterior, and also the spinous line. Check for the symmetry. We should be meticulous. We should touch every corner. We should not have early search satisfaction. If we are getting a vertebral fracture, we should also see for the lumbar, for the rib fractures, soft tissue injuries, sternal fracture, kidney injury, everything. We should obtain a clinical history. If the patient is having a neurodeficit, then simply reporting the burst fracture will not be enough. We should refer that patient to the MRI, and also we should search for the evidence of injury to the posterior ligamental complex. So that was all. Thank you.
Thank you so much, ma'am, for such an informative information. Any question? Any question from participant? Ma'am, can I ask you one question?
Yeah, definitely.
It's a basic question. So, what are the difference between MRI and CT scan, and what precaution should be taken by the patient before and after the procedure for CT scan? And
See,
contraindications scan.
Yeah, CT scan, we are using a ionizing radiation. In MRI, we are using a magnetic field. So CT will give a very detailed appearance of the bone. MRI will give a detailed appearance of the neurological soft tissue. So that's the main difference. We are using a different kind of radiation. For CT, the contraindication is pregnancy. Because it will cause the ionizing radiation, it is harmful to the fetus. Okay. Another contraindication for CT, there is no as such contraindication. The contraindication is pregnancy. Or if you are planning for a pregnancy, then we should be careful. Okay. On MRI, the contraindications are pacemaker, stent, they are not compatible. Metallic implant, which are not compatible with the magnetic field. So earlier they used to use the steel implant, but now most of the cases they use the platinum implant, so they get MRI compatible. So in MRI, if you are having a pacemaker, if you are having a cochlear implant, so and also the early pregnancy, the first 3 months of the pregnancy, we should avoid the MRI, but not contraindicated. If there is life-saving emergency, then we should do it.
Okay.
Not any precaution for CT as such, but we like the patient to remove the metallic implant so that there is no artifact. In MRI, you should always remove all the metallic implants. We should always tell the patient, the technician, that if you are having any pacemaker, stent, cochlear implant like that.
Okay, thank you so much. Now I would like to invite Dr. Subhash Wage sir, the president of RVPJ, for sharing his views.
It was
Dr. Wage.
excellent presentation by madam as usual, and I'm very much thankful to Amita madam. As despite her busiest schedule, she had given time for us, and whenever we call her for giving lecture on our platform, she obliges us at a very short notice. Even today, she joined after completing a one report, and when I contacted her, she said that she was doing drafting a one report. Now after that, she joined. So she's having such a busy schedule. Despite that busy schedule, she had spared time for us. I really thank you for your generosity, madam. Thank you very much, and I expect in future also the cooperation like this. Uh, and I would we would like to see you as a chairperson in our upcoming Diagnocon
So that I
conference
will
on
try, sir. That I will try. I
MRI.
have some family commitments this year, but I will definitely try, sir, and I will let you know.
Thank you very much, madam. Thanks once
Uh,
again.
Ma'am, there is one question for you
Huh.
in the chat box. The patient suffering from diabetes mellitus type 2 on medication metformin, can she
Yeah,
or
yeah, yeah. No
then
contraindication. No, no, no.
no
You can
contact?
do CT or MRI. Definitely no contraindication.
Okay, ma'am. Yes, thank you.
Medications will no. Only thing is that if we are opting for a contrast in CT and MRI, and if the patient is having a creatinine, high creatinine, then we don't do a contrast study, but we can do CT and MRI.
Yes, yes. Thank you, ma'am. So
Okay.
now we are towards the concluding our webinar. So here I am again for the vote of thanks. So first of all, the first and foremost thanks to Dr. Amita Thakre, ma'am, for giving us such an provoking and informative presentation. This is a really valuable experience for all of us. Ma'am has,
Thank
in a
you.
very short time, ma'am has guided us about what is the CT scan, what is the checklist for CT scan, what is the brain window, bone window, or different classification of CT scan and whatnot. So thank you so much, ma'am, for being with us. I would also like to thank our organizers, technical team for their generous support, which made this event possible. And finally, thanks to all of you, all the participants for being here and for your active participation. We hope you will found this webinar informative and engaging. We look forward to see you again our next event, which will be on next Saturday on 23rd August on CT abdomen and diagnosis. And we all request everyone to definitely join our diploma and certificate courses, go through it. And thank you once again to all of you. Have a nice day. Good evening.
Thank you. Thank you, sir. Thank you, ma'am.
Thank you.
Thank you.